This week on Africa Update.
The situation in Nigeria right now, like we did say again, right now we have 40 cases, confirmed cases, out of about 830 suspected cases.
We'll be looking at the Mpox virus and other matters arising in the African continent. So stay with us, we'll be right back. Welcome back to Africa Update, reaching you from Abuja, Nigeria's capital, on Trust Television, and I'm your host, Chiamaka, Nwanfor. Now this week we're looking at the Mpox virus. It's a growing concern. It's quite endemic in Africa. DRC Congo has a lot of cases and deaths. As of 2024, the Mpox monkeypox virus has been experiencing a significant resurgence in Africa, with outbreaks reported in at least 15 countries across the continent. The DRC is the most affected, accounting for approximately 90% of the cases. The new variant of the virus, which appears to be more transmissible, has also emerged in the DRC, with cases spreading to neighboring countries like Rwanda, Uganda, Kenya, and Burundi. Other African nations reporting cases include Central African Republic, Republic of the Congo, Nigeria, Cameroon, South Africa, Ivory Coast, Ghana, Liberia, Malawi, and Mozambique. The overall case count across Africa has surged to over 2,000 cases, with at least 13 deaths reported this year. WHO has declared these outbreaks a public health emergency, highlighting the urgency of the situation and the need for international support, including vaccines, which are in short supply on the continent. Now, in Nigeria, the NCDC, with other health stakeholders, held a briefing, and here's what they have to say.
Well, for Nigeria, we told them the situation in Nigeria right now. Like we did say again, right now we have 40 cases, confirmed cases, out of about 830 suspected cases. We still do not have deaths. We have no deaths at all, which is encouraging. But more importantly, what we've been doing since the outbreak, like we told them again that ever since the fake was declared, that this public health emergency of international concern was declared, we in Nigeria again declared our own EOC, Emergency Operations Center, for similar reasons. And we established our incident management systems. We did our incident action plan in terms of what and what we're going to do for actions and how it's going to cost each area again, using the different pillars. And also we've met with the state governments and state commissioners of health in the states, basically to let them know that at the subnational level, they themselves have to establish their own emergency preparedness and response teams and capabilities and action plans, which we do with the support. And they are going to do that too in conjunction with their various local government areas. The essence is that the problems again are at the subnational level. That's one. That's in terms of coordination and incident management system. The other area is surveillance. Looking at the number of cases we have in the country, about 40, quite a number of them are in about 12 or 13 states. A number of them within the south, southeast, some in Lagos, some in Ogun, and up north there, the central. And the distribution again, and our plans now are to target those states so that you can reduce the number of, you can actually carry out active surveillance to detect more cases. In detecting cases again, we have case definitions. And of course, in those areas again, you need to detect. How to detect? We have to beef up our laboratory services in those things. All the cases we've seen so far were confirmed using genomic sequencing in 2 labs, NRL, National Research Lab in Abuja here and in Lagos. But because of the spread, what is happening, we need to increase the number of laboratories we're going to use again to test.
What Dr. Jide Idris has to say about the Mpox cases in Nigeria, that's been the DG of the NCDC. But I have joining me to discuss virtually Dr. Agbor Ebuta, is a consultant family physician and one of the Vice President Medical Initiative for Africa. Doctor, good afternoon. Thank you for joining us on Africa Update today.
Good afternoon. It's good to be here.
Okay, so I don't know, Eve, were you able to hear what the Dr. Jide Idris was saying?
Yeah, Dr. Jide Idris, the DG, he just gave us a recap and basically an update on what the situation is. And indeed, it goes to show that they are trying to put up a robust response, which is commendable. And indeed, it won't be the first time we are dealing with public health emergencies. We've had Ebola, we've had recently COVID, we have an ongoing cholera infection in the public health space, we have Lassa fever, and obviously now we are contending with Mpox, which has, of course, an international dimension, because the WHO and the African Center for Disease Control and Prevention has gone ahead to declare it as a public health emergency of international concern. So indeed, the robust response based on the comments of the DG goes to suggest that Nigeria is taking the necessary steps.
All right, then. Now, let's look at this holistically. How is the spread of Mpox in Africa different from other regions in 2024?
Okay. First is that this particular strain is different from the strain that was responsible for 2022 and 2023 outbreak. The strain responsible for 2023 and 2 outbreaks was the clade 2 substrain, but the particular strain involved now is clade 1 substrain B. And to a large extent, it has behaved epidemiologically different in that it has spread more rapidly than predicted from the outbreaks of 2022 and 2023, because in 2022 and 2023 consecutively, we had outbreaks that were less than, cumulatively less than 10,000 in the combined years. Or less than 15,000 for both years, but presently only in 13 countries that have been reported to be infected, to have cases. We are recording over almost 20,000 cases in each of those countries. And of course, in the Democratic Republic of Congo, where we have the epicenter of this outbreak, we've recorded more than 15,000 suspected cases. This is unprecedented, given that we are just halfway through the year. But and it is the cases we have is double what we expect from previous pattern. That again is a challenge. The second aspect of it is that you've also had cases spreading to neighboring countries that did not have this particular strain in question and did not have this pattern of spread. For example, just across the Tanganyikas Lake in Burundi, where you have about 40 districts, more than half of the districts in Burundi are affected, about 22 districts. And the pattern of spread suggests that this spread may have preceded the concerns, the public health concerns about an ongoing outbreak. So it means that it is quite entrenched in the system, and the health systems in Burundi fail to detect it in time. Again, you move up a bit to Rwanda. Rwanda, probably about 4 cases confirmed. And then in Uganda, you have about 2 cases, and then 1 case in Kenya. But these numbers also should be viewed from the context that we do have weak health systems that may not be able to dictate all cases or come to a conclusion about confirming the cases that are present there. So indeed, you have a spread that is beyond the usual geographical distribution. Then the third factor is that it has gone to as far as 13 countries, and because of the current trajectory, it is projected that it may get to other countries like Europe because of the significant factors like globalization, people travel, and the rest. So it's a problem that may require interventions across continents. You may require interventions and collaborations amongst multiple health organizations. And that's why it's important, because if you cannot take care of this issue, just like when we had COVID, you had intergovernmental and international organization collaboration. So we expect some level of interaction amongst international and subnational entities. Okay. That's why WHO has put this forward, and the African Center for Disease Control and Prevention has also come up with a plan.
Doctor, can you hear me? All right, so
yes,
I can
please.
see that you have quite a lot to say and we'll have questions. So let me just like pause there and then ask this something, because you said something about strains. Can you tell us the difference between the clade 1 strain and the clade 2 strain, and the impacts they have on the carrier and of course the people generally?
Well, the difference is just basically a genetic material. So the difference in the lab is just basically their genetic material. But what we have seen is that they may behave differently in the community, because clade 1b appears to be transmitted much more efficiently than clade 2 that was responsible for 2022 and 2023. That is one. Then that's number 2 rather. And then the third thing is that we seem to be seeing a significant case fatality rate that is being adjusted upwards. But something that appears to be unusual is the behavior of this strain. In South Africa, for example, the people who are most affected are the immunocompromised, people who are people living with HIV, whose immunity has been weakened to a large extent. However, in Congo, in the Democratic Republic of Congo, we have noticed that the population affected are the under 5, and we surmise that this population are significantly affected also by malnutrition, which has weakened their immunity. So, to a large extent, it's clear that low immunity seems to be driving clade 1b. But that pattern is going to emerge as we continue to monitor the outbreak, because for us to have a full definition of the pattern of this particular outbreak, you would need to monitor it for a while, collect data, analyze, and that behavior is very fluid at the moment.
Okay, so doctor, is it safe to say that this clade 1b it's of a more dangerous strain than the clade 2, and is it adaptable? Does it seem to be adapting to any measures being brought up, anything like that?
Well, indeed, more people have been affected, and we predict that there may be more deaths. So to a large extent, we think it's more of a problem than the previous strain, to answer that question. About adaptability, that data has not emerged, but we do know that it is being transmitted more efficiently. That may suggest that it has adapted to natural measures to a large extent, but the fact remains that we are yet to establish that. We can only hypothesize and say that it may be because it's transmitted, more people are affected, and it appears to be much easier to transmit. It may have undergone some changes, but that is in the region of hypothesis presently. We do not have that data.
Okay, now, so let's go to the clinical and viral aspects of what we've talked about. It was still on it actually, according to strains. Now, as a doctor, do you know if there is any new treatment or preventive measures being developed for Mpox? And doing research for this, I saw that this thing has been here since the 1970s, and somehow they've not been able to put it in a box and lock it up and send it away.
Okay, yes, as you pointed out, some of the first human cases were reported around the 70s. But prior to that, some monkeys that were moved from Singapore to Denmark were discovered to have fallen ill and, of course, developed symptoms. And when they were screened, they found out that there was this new virus that had some characteristics like the smallpox virus. But because it was found in monkeys for the first time, they named it monkeypox. But that has since changed now, and we call it Mpox, because we find out that monkeys are not the natural host to a large extent. But in terms of interventions, in terms of treatment or prevention or immunization or vaccination options, because the smallpox virus, which has since been eradicated in the late 70s, has some characteristics similar to the Mpox virus. The vaccination for the smallpox virus put forward. But over time, because of research, we now have several vaccine candidates, and we do have several vaccines in the market. The Japanese have produced a vaccine called the LC16, which has little or no side effects and has been shown to be very useful in cutting down, in providing protection as much as to 85% of the populations that are vaccinated. You also have the VCAM 2000 vaccine and the MVA vaccine. These are all vaccines that have been shown to be potent, and these are vaccines that enter the immunization or the global vaccine space only not too long ago. So that really shows that there has been interest in this field. Unfortunately, that interest took quite a while to develop, and we are not surprised because this health condition is not had not achieved global dimension. It was mainly a condition that was common in the southern part of Africa, mainly in the Congo, in the DRC, Democratic Republic of Congo, and the surrounding countries. So, of course, countries would adjust their health security interest based on health conditions that have importance or pose a direct risk. But because this Mpox seems to be showing a tendency toward global spread, there has been heightened interest. On the third arm is that we now have a specific medication called the Mpox medication. Mpox medication is usually taken for 2 weeks, and has been shown to be very useful for patients who have Mpox and who may have immune compromise and are at risk of the very severe infections. This is very rare. It's not very common, but we do have patients who have Mpox affecting their cornea, affecting their brain, and that when that happens, we call it keratitis for the eye and encephalitis for the brain. For those patients, they are candidate for the Mpox medication, which, although very expensive, is very useful. But I'm not sure that we have that on ground. What I know is that the federal government is making effort towards getting a significant store of the Mpox vaccine through several platforms and frameworks, through donor, through purchase, and all of that.
All right. So now you mentioned something about the virus, and I also want to ask this on a global scale. What are the risks, and just of this spreading beyond Africa to other parts? And also, is there a reason why we seem to have it more prevalent in Africa? Is there something in our gene that makes us more susceptible to the Mpox virus?
Okay, in terms of the risk of global spread, for most health conditions, especially viruses, there's always that potential for global spread. But sometimes the tendency towards the intrinsic capacity of the virus to be transmitted, the transmissivity of a virus, also plays a role. We may not be able to say, well, we can say categorically that the COVID-19 virus was much easier to transmit because being a respiratory virus, but the Mpox virus is a little more difficult to transmit because you need sometimes body fluids, direct contact with body fluids, and not so much with respiratory, and then vertical transmission from mother to unborn child and recently born child. So to a large extent, transmission is not as heightened. So the risk of global spread, although there, cannot be anything compared to things like the SARS virus and the coronavirus, COVID-19 virus, as the case may be. And then your second question, what was it?
Is there anything about the African gene that makes us more susceptible to this disease?
Oh, yes. Well, there's really nothing, there's no information in that direction. But what we do know is that the Democratic Republic of has been the origin of several viruses, like of public health concern internationally, like the Ebola virus, and now the Mpox virus. To a large extent, we need to also understand that because it is transmitted following close contacts with the natural hosts, which are typically rodents like rats, squirrels, mice, bush rats, and the rest. And populations in this part of the world, Africa, tend to interact more with nature, tend to go to the farm, and they are more likely to come in contact with the natural host. So that is a factor. The second factor, obviously, is that malnutrition is high in Africa. Tropical diseases are high in Africa. So to a large extent, immunity is also a problem. So lower immunity is higher risk of being infected, higher risk of transmitting to other populations. Okay. A third factor may also be the communal way we live. We live in communities that are closely knit. We interact together. We eat in communities. We do activities together, and we tend to care for each other on a closer care for people who are ill. Usually happens in the community and usually involves several members of the family, as the case may be. So the chances that a person in a community would interact with a rodent, a rat, a squirrel, and any of the other rodents are higher in Africa. The chances that a person will present with some level of adjusted immunity down that increases their risk is also higher in Africa because of poverty. And then lastly, because of our communal existence, that is also a factor. But outside that, there's been no genetic explanation of susceptibility by the African population.
All right, doctor. Just in 15 seconds, if you can, what can we do on our own to prevent contacting the Mpox virus?
The Mpox virus is contacted by close contact with people who have those eruptions on the skin. So when you meet people who are ill with eruptions on the skin, you have to avoid close contact with them directly or with any other part of the environment they've come in contact with. And if you were to develop symptoms that last 4 to 5 days and subsequently have rash, you should report to a hospital. And then and of course, from there will be escalation along the chain of command.
All right. Thank you so much, Dr. Abutu, for being with us, Dr. Agbor Ebuta, for being with us today on Africa Updates, giving us more insight on the Mpox virus and the rising cases in Africa.
Thanks for having me. It's a pleasure.
Thank you. We'll be speaking with Dr. Agbor Ebuta, who's a consultant family physician, and he's talking to us on the Mpox virus in Africa, what's happening and what we can do to prevent it. When we come back from the break, we'll be looking at the second largest diamond in the world. Just stay. Welcome back. Thanks for staying with us on Africa Update. Now, before the break, I told you we were looking at the biggest diamond in over a century has been found in Botswana. And this is the second largest diamond in the world at 2,492 carat. Africa News has more.
Botswana has announced the discovery of the largest diamond found in the southern African country and the world's second largest. The exceptional 2,492 carat stone was presented at a viewing ceremony Thursday. Canadian mining company Lucara Diamond Corps said in a statement that it recovered the rough diamond from its Karowe mine in Botswana's north, adding it was a high-quality stone and was found intact. It was located using X-ray technology. Botswana is the second biggest producer of diamonds. Scientists say natural diamonds are at least 1 billion years old.
What a very, very lovely discovery over there. Another invention happened here in Nigeria. And Nigeria struggles with food insecurity. Young Nigerians and startups are seeking to revolutionize the agricultural sector through technology. In the state of Kaduna, Shamsuddin Jibril invented a drone that can detect crop diseases. Al-Hassan Bala has a report from Abuja from the VOA.
In their small workspace in Nigeria's northwestern state of Kaduna, 24-year-old Shamsuddin Jibril and his team create drones designed to detect crop diseases and spray insecticides. A 2022 National Agricultural Survey showed that some of the country's farmers lost up to 80% of their crops to pests and diseases. Jibril says his startup company, Vora Robotics, is helping develop more efficient farming practices.
We use local available material to develop it in order to be cost effective. These are manufactured local drone that we did. Our main focus is the agriculture. We are trying to see how we can bring the solutions to them and also to help them to detect diseases in their farm.
Jibril says that the drone takes photo of crops and sends them to an application he and his team created that analyzes and provides results within minutes.
On that app, it will show you the symptom of that and the treatment that you should do for that farm. And also it will tell you how the chemical you're supposed to use. Maybe, there's different type of chemical, acid pesticide or for the gas or insecticide for the insect.
In 2024 alone, ginger farmers lost over $7 million in crops to disease. Small-scale farmer Lawal Ibrahim Dambusha says the inability to detect crop diseases early put farmers at a major disadvantage.
If we could get a drone that detects crop diseases, it will help us a lot. As farmers, we don't really know much about diseases at the initial stage. We are more familiar with them when they become serious. Honestly, seeing how this machine flies and works, it is a great news to us.
Agricultural experts say the Nigerian government can do more to promote the use of technology in the agriculture sector. One of them, Ezekiel Bulus Doka, says technology like the crop diseases detector can be a game changer in Nigeria's search for food security.
There are so many innovations that would have transformed Nigerian agriculture. But how those in authority, how do they accept it? And how do they push it forward? How do they fight for it to be scale up?
Jibril and his team are hopeful that they will receive support from the government and the private sector to expand their innovation to the entire country.
And that's much we have for you today on Africa Update. I hope you have been enlightened, educated about the Mpox virus and every other thing happening on the African continent. Don't forget to follow us on our social media platforms, on our YouTube live stream for more news, documentaries and programs. I am your host, Chiamaka, and I see you same place, same time next week. Bye for now. Stay safe.